Hello, and welcome to Module 4 of our Pharmacist Education Program focusing on COVID-19 vaccinations. Today, we're going to take a global, national, and local look at achieving vaccine equity during the COVID-19 pandemic. We're going to look at current situations as well as future implications. At the completion of this program, you'll have earned 1.5 CE credit hours. This is the fourth of an 11-part series, all of which build on previous knowledge and will culminate into a conversation regarding how we as pharmacists in Louisiana can use the knowledge that we're gaining and using future platforms to exchange knowledge to continue to combat vaccine hesitancy in Louisiana. My name is Sara Al-Dahir. I am a clinical professor of infectious disease and critical care at Xavier University. I have completed my bachelor's and master's from Tulane, and my first doctorate, PharmD, from Xavier University. And I'm completing my second doctorate on infectious disease epidemiology, specifically global disease epidemiology and control from Johns Hopkins University. As a disclosure, I have received funding as a consultant for both UNICEF and the WHO. I've worked on projects with regards to vaccine equity, particularly the meningococcal vaccine and the meningitis belt in sub-Saharan Africa, as well as projects throughout the Middle East looking at vaccine equity during conflict situations and COVID-19 preparedness at a health facilities level. You'll receive 1.5 CE hours after the completion of this. Though the original content was created in November of 2021, it has been updated in February of 2022. So today, we're hoping to explain the concept of vaccine equity across vaccine preventable diseases and describe current trends specific to COVID-19 vaccine distribution, as well as uptake globally. We're going to describe current trends in COVID-19 vaccine distribution and uptake nationally. We're also going to look at and try to interpret local vaccine distribution and uptake data, and hopefully develop some best practice recommendations to hit our target areas based on local data. So let's get into it. What is vaccine equity? It was Nelson Mandela, former president of South Africa, who said, vaccine equity is only impossible until it is done. So if we work from the premise that this is an achievable outcome, that equity is achievable, then it is something that we're hopefully that using interprofessional and cross-nation and within nation collaborations will be able to overcome inequities in vaccine uptake and distribution. So as we look at the reality of COVID around us, and we're looking at the evolution of variants, many of which have evolved because of lack of appropriate vaccine-mediated immunity in parts of the world in which vaccine distribution has been limited, we're really beginning to understand the need for equitable distribution and uptake of the COVID-19 vaccine. And in the context that we're currently discussing, we have overcome two significant variant evolutions, particularly the Delta and the Omicron. And when we hope to look at how we might be distributing these vaccine doses across all countries, we have discussions around, are we going to determine our distributions on a need-first basis? Or are we going to do it also as well as without regarding the recipient's or nationality wealth? Are we going to look at the burden that is disproportionately placed on healthcare workers, particularly essential frontline workers, and as well as what is the distribution of those most vulnerable populations within any particular country? So what does vaccine equity mean? It means that vaccines should be allocated equally across all countries, regardless of their developmental or economic status. Access to an allocation of vaccine should be based on every human to enjoy the highest attainable standard of health without distinction of race, religion, political belief, economic, or any other social condition. And this is really important to understand that this is a goal that we're trying to achieve. It must be contextualized within the realities of a situation. For instance, we must be cognizant of an individual's political or religious beliefs. It is not sufficient simply to say that we have done adequate distribution of a vaccine without giving consideration to local, regional, national, or even international interpretations based on religious or political belief as to whether or not the vaccine can be appropriately taken up within a community. So vaccine equity is not simply on the distribution side. It must take into account the uptake side. So as we have noticed, religious and political beliefs have borne a great deal of the burden on the impact of vaccine hesitancy. This needs to be done within the context of what is economically attainable. We must understand an individual's social conditions, not only their education, but their health education, and how that impacts not only their access to vaccine distribution points, but also their understanding in the uptake of a vaccine. And particularly in the United States, we understand much of this is benchmarked around the experiences of race and disparities within the community. We are going to address across all modules content related to this one statement regarding what is vaccine equity. So we need to frame vaccine cost in the context of healthcare cost and spending. Within high-income countries, less than 1% is spent on the average cost to cover vaccinating 70% of the population. But when you look at low-income countries, they would need to increase their healthcare spending by 56 or nearly 57% on average to cover the cost of vaccinating 70% of the population. Where are these costs coming from? It has to do with the infrastructure of vaccine distribution, storage, and uptake. It has to also do with the infrastructure of the healthcare system and whether it is primarily organized around referrals to tertiary centers for acute care problems, as well as the strength of the primary healthcare network. In high-income countries where primary healthcare networks are strong, well-funded, well-staffed, obviously there would be a decreased impact or economic burden in adding the additional workflow need of vaccinating the population. In countries that lack resources with regards to healthcare staffing, even the healthcare infrastructure, there is a good deal of forefront work that will need to be done in order to attempt to vaccinate 70% of their population. So let's look at some global and regional implications with regards to vaccine equity. In the very beginning of the pandemic, there is a coalition of countries, and it was the majority of the globe, which early identified that vaccine procurement strategies around vaccines which were in development would need to be equitable. So COVAX was founded to participate in a negotiated vaccine procurement pricing with the industries that were making the vaccines. Though we understand that many of the vaccines were produced within the scientific development was within the United States and Europe, we do understand that much of the manufacturing of these vaccines were occurring in facilities globally in which vaccines have traditionally been made. As we learned in the vaccine clinical trials lecture, previous vaccination facilities that were dedicated to influenza or pneumococcal vaccine were now being redirected toward the production of COVID-19 vaccines. So though we tend to think of the frontline vaccines as a product of the efforts of primarily the wealthier nations in the world, The reality is that much of the vaccine production is occurring globally. Therefore, there should be global and cooperative negotiating efforts with regards to procuring the vaccine at affordable rates across the globe. But procuring or buying the vaccine is simply not enough. We then need to have systems in which it might be distributed. Now, we can all remember kind of the Herculean effort of the cold chain preservation and distribution in the United States. And without the existence of the cold chain modalities, then these vaccines are rendered useless. And in the United States, we have sufficient airports and large truck delivery systems that can preserve the necessary temperature of our vaccines. This doesn't exist in the majority of the world. That is why in places like Malawi and in South Africa, though vaccines were procured for them, as well as delivered to those countries, they were wasted rather early in terms of the total number of doses because they did not have the cold chain preservation system to distribute it throughout the populations. Also, for distribution, you need to have adequate roadways to get primarily into some of the more rural areas of certain countries. And in some countries, 80% of the population can be identified as rural. Now, once the vaccine arrives, does that facility have the necessary storage to store the vaccine? In order to do cold chain storage, you need electricity. Now, there is something called the Icelandic refrigerator, which is a deep storage unit, which has been bought through negotiation attempts by UNICEF and Gavi and many countries in developing in parts of the world, particularly those that are identified as Gavi countries, have the Icelandic refrigerators. The benefit of those is that they don't require 24 hours of electricity to keep it cold. But they are expensive and they are few. And they do need electricity to get to the point where they are able to go into the sub-freezing temperatures and preserve it. So not all facilities in the world have the necessary ability to store the vaccine. And should they have enough to store it, do they have a strong enough immunization system to deliver the vaccines? Most countries since the 1980s have developed something called the Extended Program on Immunizations. And they have revised their immunization schedules and they have created unique classes of healthcare workers that are simply dedicated immunizers. They work globally with efforts that are funded by the World Health Organization and UNICEF. They usually complete certification courses that are about 2 years long, and they do not only clinic-based immunizations, but house-to-house immunization programs to make sure that typically there are sufficient numbers of children vaccinated against vaccine preventable diseases. We now need to take those trained immunizers and target them toward adult immunization activities. And in so doing, it is going to pull resources from one area of the healthcare infrastructure. Finally, as we begin to release the vaccines within the communities, how likely are the communities to take up the vaccine? So we need to understand historical inequities with regards to vaccine uptake and distribution and how that might feed into vaccine hesitancy, or what are some religious, political, and social concerns that contribute specifically to vaccine hesitancy? With historical inequities, I always like to give the example of what happened to the polio vaccinators in Pakistan. Unfortunately, in not less than a decade ago, several of the polio vaccinators in Pakistan were commissioned by members of the CIA to use the opportunity while immunizing against polio and measles to do blood draws on the children in certain border Pakistani towns, particularly that bordered Afghanistan. And this information came out, and it was very well known that it was not only a mass vaccination program, but it was also a surveillance program. And unfortunately, when the Pakistani communities, particularly those that are of Pushtun descent, became aware of this, they began targeting the polio vaccinators, and their lives were actually put at risk. So when attempting to reach particularly these communities, and particularly after the fall of Afghanistan, there are long histories of historical inequities as well as social mistrust that will make it difficult to vaccinate those communities. And it truly is a unique brand of vaccine hesitancy. Vaccine hesitancy in the United States, as you know, is really predicated upon not only political affiliations, but historical misuse of certain populations with regards to medication testing. Vaccine hesitancy is not new. It is actually quite old. And prior to the pandemic, there were strong calls to move from what was known as vaccine nationalism to vaccine equity, which they were looking for modern strategizing attempts to make sure that vaccines are not considered simply a national priority, but they are considered a global priority. And what happens is when we look at vaccinations as only a national strategy, it perpetuates the long history of powerful countries securing vaccines and stockpiling vaccines as well as therapeutics at the expense of the less wealthy countries. And what we have seen, particularly with the COVID-19 pandemic, this has resulted in the ability of the virus to mutate and have mutations which even supersede the vaccine's effectiveness. So in releasing vaccines, we need not to think about it as a national strategy, but as a global strategy. And this is a term that's known as global health diplomacy. So achieving global equitable vaccinations will not only boost economies, but they'll improve global health security and help achieve what are known as the United Nations Sustainable Development Goals, of which there are 17. The SDGs are benchmarks around which countries are assessed to determine their level of development, and they are looked at where they are only compared to themselves from a baseline measurement moving forward in the future and looking at proportion improvement. The goals focus around health goals, social justice goals, economic improvement goals. And what's most important about the Sustainable Development Goals is that for one of the 17 goals to be achieved, all of the 17 goals need to be achieved. That they not only relate to health, but they relate to poverty, education, and many, many more things, as well as climate and climate crisis. The organization Gavi, which we're going to talk about later, was developed at the beginning of this century to help nations achieve their sustainable development goals around health equity. So what is Gavi? It was founded in 2000. Its focus is on primarily childhood vaccinations in low-income countries, such as in Southeast Asia, Africa, and South America. What they do is they participate in favorable vaccine procurement strategies by negotiating directly with the industries that produce the vaccines. And they have successfully reduced through their strategizing and their procurement of bulk vaccines for countries that are unable to participate in economic negotiations as an individual nation. They've been able to reduce what is the 1,200 childhood vaccination schedule, which is the vaccination schedule up until age 6 years old. In the developing world, it is averaging at only $28. So what in the US costs about $1,200 for the vaccines alone, in other parts of the world, has been reduced to $28. And Gavi has resulted in tremendous successes. And I like to refer to two countries that are kind of the hallmark of Gavi's success. If you look at Bangladesh, there's nearly 98% vaccination by 12 months of age. 98% of their children are fully vaccinated. If you look at Senegal, which is in sub-Saharan Africa, Again, through Gavi support, they have reached 98% vaccination of eligible children of the immunization schedule by 12 months of age. And this is tremendous compared to 20 years ago, where those numbers were less than 40%. But they don't simply work on bargaining with the cost of buying the vaccine for the country. They also look at training vaccinators, ensuring countries have those Icelandic deep freeze refrigerators that don't require 24-hour electricity, because many clinics in the world do not have 24-hour electricity. They look at training programs for the healthcare workers, and they also look at opportunities for storage and revisiting the vaccination schedules to move to more cost-effective vaccination schedules. And most importantly, they participate in data collection, analysis, and feedback at a nation and regional level. The major partners are the World Bank, UNICEF, the World Health Organization, the Bill and Melinda Gates Foundation, as well as individual organizations. In 20 years, they have successfully resulted in the immunization of 65 million children globally. So naturally, with the evolution of the COVID pandemic, Gavi was called upon first. And there's a group called COVAX that was developed using much of the Gavi model. Immediately, 194 nations joined this coalition, and they prioritized what they were going to do. They were going to accelerate the development of the COVID vaccine. Once the vaccine was developed, they would then accelerate the production of the vaccine. And we know that number one occurred, that the development occurred within 18 months, that production had occurred within probably close to only 2 months, global level scales of production. And now we need to sit there and say, how well did they do in terms of distribution of the vaccine? It was estimated that 6.5 billion doses for adults initially were calculated to be administered worldwide to date. 1.5 billion vaccines are produced monthly, and 5 billion doses to date have been procured. The goal was to have 40% of all countries vaccinated by the middle of 2022, so that's this summer, and 70% by the end of 2022. And COVAX, of course, works under the cooperation of CEPI, Gavi, WHO, and UNICEF. And they work on the principle that no one is safe from COVID until everyone is safe from COVID. So when we go to the global section, we'll see how well they are doing toward reaching this goal. So what are the top 10 countries that have the highest vaccination rates? And by that, based on their guidelines of who is eligible for vaccination, the top 10 countries that have 85% of eligible individuals completed vaccination actually are an interesting group of nations. The United Arab Emirates and Brunei are two of the wealthiest countries in the world. It's actually Brunei is number 1, Qatar is number 2, and UAE is number 3. Malta, which is of course a very small nation, has 85%. Portugal, which has a very extensive universal healthcare coverage system and a very strong socialist healthcare coverage system, as well as Chile, have 85% of their populations vaccinated. China, which works on a socialist communist model of healthcare advancement, has achieved 85% via their reported numbers. Cuba, which works on a similar model as China. And then finally, Singapore, again, one of the top 10 wealthiest nations in the world, have achieved 85% vaccination of eligible individuals. There are a total of 44 countries that have achieved 70% vaccinations. Once extending out of this list, which is within the Middle East and Southeast Asia and South and Central America, as well as only one European country in the top 10, we see that the remaining countries, which that only 70% have been achieved, are primarily in Europe, Some are in Asia, by that I mean Japan and South Korea and Taiwan, as well as Arabian Gulf countries such as Qatar, not Yemen, Qatar, Oman, and Saudi Arabia. The United States is only at 65.4% as of February 2022. So if we were to look at this and say, well, what are some commonalities that these countries have in being able to achieve their 85% goal? Well, we definitely see that wealth is a component, though it's not all a complete component, because Portugal and Chile and Cuba certainly are not wealthy countries. Strong healthcare systems, a strong healthcare infrastructure, such as Portugal, Chile, and Cuba, were necessary to achieve this. Vaccine mandates within a country to ensure the economic prosperity are a component of this as well as when looking at China, excellent surveillance systems with regards to the need to encourage and promote and mandate vaccinations. Now, there's a lot of different opinions. Can the United States actually follow these models, or do we even want to follow these models? And that could be a discussion for later. Now, what about the bottom countries? Now, we see tremendous similarities across these countries. The countries with less than 2% of eligible individuals vaccinated, many of them are in sub-Saharan Africa. By that, I mean Burundi, Chad, Ethiopia, South Sudan, Cameroon, Nigeria, Tanzania, Madagascar, Mali, Burkina Faso, Malawi, Niger, and Sudan. So every country on this list, except for Haiti and Papua New Guinea, are in sub-Saharan Africa. Papua New Guinea has historically had significant challenges. It's not just the COVID vaccine, but also childhood immunizations with achieving their sustainable development goals. And Haiti is still undergoing continuous economic and political as well as geographic instability, and has not yet appropriately recovered from the massive earthquake. There's the largest shared component across these countries is poverty. These countries are all identified as low-income countries in which the average income for a household is less than $700 per annum. When we look at those that have achieved less than 20% vaccination, there's 41 countries. Again, they continue to be countries that are in sub-Saharan Africa. And another theme that emerges, they are conflict recovery or ongoing conflict countries, particularly Afghanistan, Syria, and Iraq. In addition, we see that there are continuing concerns in the Indian subcontinent as well as Eastern Europe with inappropriate vaccination coverage. So if we look at this map of the globe, the dark blue is favorable, and we can see themes across the dark blue countries. Canada, which has a strong socialized, and they have a small population, they're a wealthy country and a strong socialized medicine system. We could look at Southern America, and we see those themes there, as well as China and Australia. When we look at the countries where we're looking at the light yellow and light green, we could see the majority of them are in sub-Saharan Africa, where there are tremendous inequities, not only with regards to healthcare, but resource allocation, ownership of resources, regional instability, as well as the effects of post-colonization, or we might even say ongoing colonization. Operation Warp Speed was developed to address global vaccine security. And this is exactly what has occurred. That though it was intended that there would be equitable distribution with a needs prioritization, regardless of the wealth index of the country, what ended up happening is that vaccines were allocated according to national rather than global priorities for vaccine security. that COVAX cannot be an afterthought, and that's what appears to be happening now. That the access gap, when we look back to what happened with rotavirus, the rotavirus vaccine, that countries that were Gavi eligible countries that were promised the rotavirus vaccine at affordable cost for their children, that those companies withdrew their agreements with countries such as Malawi and then prioritized the supply of the rotavirus vaccine to countries which would pay a higher price for them. So it's not just a failure that happened within the COVID vaccine realm, it also had happened and could have been predicted looking at the experience of the rotavirus vaccine. And the result of this for the COVID-19 vaccine has been economic instability globally. So we need to look at the need to shore up low and middle income countries, that's what LMIC stands for, and to shore up their access levels the same as high income country populations. And that is the only way that we'll be able to achieve global vaccine security, as well as to achieve an end to the pandemic. And this was called upon by a group of a task force that was commissioned to look at global vaccine equity, and they published in the Lancet. But we also know that several countries in the world, rather than equitable distribution, early were designing and taking advantage of global vaccine stockpiles. And that happened within the United States, and that has been happening for the last decade. A term in the Journal of Pediatric and Child Health that emerged in the last decade was vaccine apartheid. And this is not the way to end the pandemic. That COVAX achieved important results in shipping, but in terms of final target delivering, it's still not as good as compared to richer countries. As of August of last summer, COVAX could only immunize 4% of Southern Africa, as in sub-Saharan Africa, and 50% of South America only. So though COVAX was well designed and well intentioned, the implementation phase fell short, and there's a term emerging in the global literature that's characterizing this as vaccine apartheid. And those who, even though they're not considered the most vulnerable group for lack of vaccination, but those who bear the greatest burden of any pandemic, of course, the children, because we are noticing that though their susceptibility to COVID might be lower, they are experiencing parental losses, nutritional burdens. There's an increased reports of domestic violence within the home, decreased education. It's impacted other routine immunization schedules, which makes them vulnerable to future diseases that used to be eradicated. So we will end there with our look at global vaccine equity, and then we will move into national vaccine equity.